I welcome you all once again to the Onco Bridge 2025 Clinical Updates in Common Cancers. And with great pleasure, I would like to invite Dr. Asim Kumar Samar, who is Senior Consultant Medical Oncology at Bhagwan Mahavir Cancer Hospital and Research Center at Jaipur, for the welcome and introductory note and to take the proceedings forward. Over to you, sir.
Yeah, thank you. And I wish to welcome all the faculties and our esteemed doctors for this webinar where we will have the wonderful discussion about the breast cancer and what is new in the breast cancer nowadays, what are the trend which is going on worldwide, what are the latest researches which have come up through the various national and international trials, what is the expertise expert says about these trial results, what is the you can say the real world experiences of the our esteemed faculties, and this kind of the various discussions which we will have today, which might help our patient in the real sense, because many of the time trial results are different and our real world experiences are different. But as we have the galaxy of the stars today, doctors, my colleagues, and my seniors also. So they will impart their knowledge and their understanding about the various researches, new researches, research which have been done in recent time, what they feel about and what is their insight about, and how we can apply to our patient in the real world scenario. So this is the attempt which we want to do today. And the thing is, with the collaboration of the doctors, scientists, and researchers, uh, we can foster the collaboration and the knowledge about the particular cancer. So today's topic is about the breast cancer. Breast cancer, as we all know, it's a second most common cancer worldwide, and India also. And now the cancer incidences has increasing too much, too fast, and almost every eighth, or you can say the 10th women are affected by this cancer. So we want to know about the every step of the cancer, where we can apply the treatment, whether the part is surgical or radiation related with the radiation oncology, or with the chemotherapy specialist, or you can say the medical oncology. Various immunotherapy have emerges, and now like antibody drug conjugates are there, which have done dramatically, and you can say the results are very much favorable in the patient treatment. So we will discuss everything about this breast cancer, and we will try for that. And as you all know, the first thing which appeared in the arena of the breast cancer was surgery. In the 18th century, the surgery was developed for the breast cancer, and then the people started learning how we can best treat this kind of the cancer or the tumor. Slowly the science has progressed, and now you can see we have moved towards the immunotherapy and antibody drug conjugates, and maybe in future, in the particularly in the TNBC, there may be some CAR T cell therapy also may be available. Researches are going on, and every time the new treatment come up on the arena of the breast cancer, it automatically gets popular because it is a cancer of concern of many of the uh, people in the world. So for that, actually, this today the conference is a little bit longer because it is 3 hours around conference. So we will be strict to the time of the uh, conferences, the topics which is allotted to our esteemed faculties. And I would request to our speakers that please be adhere with the time, as the later fellow will have the time to speak about, and the question after the particular talk, we will have some one or two or three questions so that we can clarify the things. And if further questions are there, we can have the questions noted in the chat box. For that, I would like to invite our first doctor, my senior colleague, and you can say the very well-renowned doctor. He's a surgeon, Dr. Uttam Soni. Uh, I would like to invite Dr. Uttam Soni. He's a consultant oncoplastic breast surgeon at the Breast and Cancer Research Institute at Sita Devi Hospital, Jaipur. And sir will be speaking on the famous trial, INSEMA trial result, that is no axillary surgery versus axillary sentinel lymph node biopsy in patient with early invasive breast cancer and breast conservation surgery. The result is final primary result of the intergroup sentinel MEMA trial, that is INSEMA trial. So, Dr. Uttam Soni, sir, are you there? Tech team, can we contact Dr. Uttam Soni? Hello.
Hi, Asim. I'm there.
Yes, sir. Yes, sir. Good evening, sir.
Good evening. Good
Sorry,
evening.
we invited 1 minute before your time schedule.
How are you?
I'm fine, fine, sir. Thank you. So I had just given you the invitation for the first talk. You are the opening batsman for the today's webinar.
normally, my place of betting is number 3 or 4.
That's fine, but
I don't know how I'm going to face the new ball.
Maybe in the IPL you are the first opener, I guess.
Probably. Let's see. How
Yes.
Okay.
Very warm welcome to you, sir.
Thank you, and thank you so very much for inviting me here. And I'm glad that we have chosen a topic which is so close to, I think, every breast surgeon's heart. And this is about minimizing surgical intervention into breast cancer surgeries. Axillary staging is one place where we've been working for last 35-40 years, so that we can reduce the morbidity caused by axillary lymph node dissection. And we've been ways, by research and trials, wherein trying to form a group of patients which can actually avoid, we can avoid axillary surgery in these patients. Now, this trial, INSEMA trial, is about the same thing which we are talking right now. Can I have it on, please?
Yes, sir. Yes. They are sharing your screen, sir. Yeah.
Are the slides visible, sir?
Not really.
Sir, slides are visible or not?
No, they are not.
So can you confirm? Are those slides visible?
Yes, ma'am.
Okay.
Why they are not visible to me? Can everybody see the slides? I cannot see
Yes.
them. I cannot see them.
No. It's visible on our, but I don't know why it is not visible.
Okay, is it okay? I just close the program and then just log in again straight away.
Sir, can
Give me
you
1 minute.
see the top and right and top side in view option? Hello, sir.
Sir is log off, I guess, and he will rejoin.
Okay, that's fine. I'm there now. Shall we start? Shall we start?
Yes, sir, please.
Okay, thank you. So this trial is INSEMA trial, very hot topic right now, and it was very grossly appreciated at SABC this year. It's the basic title is very exciting. It says no axillary surgery versus axillary sentinel lymph node biopsy in patients with early invasive breast cancer. and breast conservation surgery. Now, they're the final primary results of this INSEMA trial. This is what we are going to discuss and take it further if it looks nice to all the surgeons. Next slide, please. Can I have the controls with me? Next one, please. This is the disclosure from the principal investigator. Now, it is one of those 4 ongoing de-escalation trials, which is they are evaluating complete omission of axillary surgery in patients with breast conservation surgery. After the SOUND trial, which showed that in patients with small breast cancer, say of the size of 2 centimeter or less than that, if we avoid axillary procedure, it is not inferior to sentinel lymph node biopsy. The secondary outcomes of INSEMA trials have been reported earlier, and the goal was to demonstrate that complete omission of axillary surgery, it does not result in inferior invasive disease-free survival, IDFS, as compared to standard sentinel lymph node biopsy that we normally do in early breast cancer patients. Next one, please. Now, the study design was, the inclusion criteria was patient needs to be more than 18 years. The tumor size is T1, T2, which is less than 5 centimeters, clinically node negative. Patient should be planned for breast conservation surgery, and obviously post-operative irradiation was must after BCS. The total number of patients were 5,230 as per the protocol. Randomization was done in the ratio 1:4. No sentinel lymph node biopsy for 1046 patients and sentinel lymph node biopsy for 4184. The primary objective was to compare invasive disease-free survival after BCS between no axillary surgery patients and sentinel lymph node biopsy patients. Key secondary objective was to compare IDFS after breast conservation surgery between SLNB alone and completion ALND patients. Recruitment was done in Germany and Austria. Sorry. Next one, please. So the analysis of the primary endpoint was done on the per protocol set due to non-inferiority study design. Kaplan-Meier product limit method was used to estimate 5-year IDFS rates, and the non-inferiority test, it was tested based on the CI of the hazard ratio from the Cox proportional hazard model to exclude the HR of 1.271 for the primary objective. Now, next slide. The sample size calculation was done as per adjusting, was done 1:4 randomization, 1 patient for without axillary surgery and 4 for SLNBs. 851 events and 5230 patients were needed in total for the first randomization. 1046 in no SLNB arm and 4184 in SLNB arm. Now, they assumed a 5% rate of patients who have to be excluded from the PP analysis. About 5505 patients needs to be randomized into the first part. The final efficacy analysis was planned, event-driven, when 851 events for the first randomization occurred in the PP set. A time-driven analysis was pre-planned after a follow-up of 5.5 years of last recruited patient in case of lower event rates than expected. So this is how sample size was calculated. Next one, please. These patients, the patients who were assessed for eligibility were 5502, of which there was a dropout of 348 patients. 157 patients had mastectomy, 118 patients withdrawal of consent. They didn't consent for the same, they withdrew from the consent, and 73 had other reasons. So the total randomization in first line was done for 5154 patients, of which PP set had, so there were 296 patients excluded from it, 252 without post-operative radiotherapy, 38 patients had to undergo axillary surgery, and 6 others have other reasons. PP said total numbers was 4858. Sentinel lymph node biopsies were 3896, and no sentinel lymph node biopsies were 962. In this, no sentinel lymph node was detected in 38 patients. Sentinel lymph node negative were 3275. Sentinel lymph node micromets in 133 patients. Positive patients who had macrometastasis was 432, and patients who had sentinel lymph node positive, more than 4 lymph nodes, they were 8. Next one, please. So when we look at baseline characteristics, as the PP said, 10.8% were aged less than 50 years. 95.2% has hormone receptor positive HER2 subtype. So this is very important. When you come to conclusion, these things will matter a lot. The median age for no sentinel lymph node biopsy patients, that is 962 patients, was 62 years, and for sentinel lymph node biopsy 3896, it was 62. Less than 65, 583, 2387 for sentinel lymph node biopsy. More than 65 is 379 for no sentinel lymph node biopsy, and sentinel lymph node biopsy is 1509. Preoperative tumor size less than 2 centimeters, we had 871 patients for no SLNBs, 3521 for SLNBs. More than 2 centimeters, 91 patients for no SLNB, and 375 for SLNB. Grading G1, grade 1 tumors, 372 for no SLNB, 1463 for SLNB. Grade 2, 552 for no SLNBs, and 2294 for SLNB. Then we have grade 3 also. Tumor type as no special type, invasive, mixed lobular carcinoma, ER/PR both negative, ER/PR both positive, HER2 status negative and positive. That's how the baseline characteristics were sorted out. Next one, please. Now, this is the primary endpoint, which is what we were looking for as per PP analysis, and the confidence interval for HR lies entirely below the non-inferiority margin of 1.27. We can see the pink line for no SLNB patients and the gray line for the SLNB patients. They all start together, but then coming at say at a certain point, they start diverging, and then we have some differences between both of these, which clearly makes says that no SLNB is not inferior to SLNB for these patients. Survival rate at 5 years. Great. Next one, please. The primary endpoint events. First, invasive disease-free survival event was invasive locoregional recurrence. In no SLNBs, we have 18. In SLNBs, we have 54. Overall, we have 72 invasive locoregional recurrence. And we can see no SLNBs have 1.9%. SLNBs have 1.4%, which is again non-inferior. Axillary recurrence, 10 in no SLNBs, 12 in SLNBs, overall number 22. Invasive ipsilateral breast recurrence, 8 in no SLNBs and 42 in SLNBs. So we can see that invasive ipsilateral breast recurrence slightly higher in SLNB group as compared to no SLNBs. Invasive contralateral breast cancer, again non-inferior. Distant relapse, almost the same in both the groups. Secondary malignancies, almost the same, again non-inferior in both the groups. And death, mortality, lower in no SLNBs, slightly higher in SLNBs. So overall, the primary endpoint which we were looking for is, it proves, these results actually prove that no SLNB is almost non-inferior to SLNB group. Next slide. Overall survival, again, pink line is for no SLNBs and the gray is for SLNB. And we can see that, there's a slight difference at certain period of time. But again, non-inferior. Again, non-inferior. Next one, please. And this is a forest plot, which very well says this side, this subgroup on your left side, on the left side is for no SLNBs, and on your right is SLNB group. And we can see that most of these, they actually land up being better on low SLLD side. Next one. The conclusion is the trial enrolled 5500 patients significantly demonstrated that omitting sentinel lymph node biopsy in clinically no negative patients with early breast cancer and scheduled for breast conservation therapy did not result in inferior outcome. Patients had very good overall survival with 96.9% and 98.2% at 5 years. And this is as good as without center. Actually, it was better as compared to patients who had SLNDs. Now, this de-escalation concept is suitable for patients. Again, the patient should be chosen very wisely, the protocol should be followed very strictly for these patients. These patients are aged more than 50 years, grade 1 and grade 2 cancers, hormone receptor positive, HER2 negative, and tumor size up to 2 centimeters. I think that's it in SEMA trial. And I don't know how we will take it, but to me, it looks like as if a new door is opening up wherein we can reduce the morbidity because of axillary dissections and axillary stagings, invasive axillary staging in breast cancer patients.
Yeah. Thank you, sir. Thank you, Dr. Uttam Soni, sir. So this is a very actually remarkable trial where you can say like when patient has a very low risk of recurrence, then you can avoid the axillary node dissection or sentinel lymph node biopsy. So, but only thing is we cannot do in the triple negative breast cancer because they are per primum they are high grade and in the HER2 positive cancer. Otherwise, if patient is in the age group of the elderly age group and low tumor size, low grade, then we should offer that, right, sir?
So one thing which is missing out here is they've reported that even HER2 positive group, that should also be excluded currently from this. It should only be for patients more than 50 years, tumors less than 2 centimeters or up to 2 centimeters, and luminal A type cancers.
Yes, that is for sure. Okay. Thank you very much, sir.
Thank you.
Thank you for being with us, sir. And now I would like to request Dr. B.S. Ankit Nehra for his topic. That is the SABC 2024. The long-term Natali data shows durable reduction in the distant recurrences in broad population of patient with early breast cancer. So Dr. B.S. Ankit Nehra will speak on that. He is a consultant medical oncologist in SCG Hospital, Jaipur.
Thank you, sir. Thank you for the kind introduction and thank you for giving this opportunity and organizers. Let me share my slide from my side.
Can you please help?
Yeah. Are my slides visible? So I can start.
I guess the screen has not been shared now.
Is it visible now, sir?
Yeah, now it is visible.
Okay. Thank you. So I'll be talking about the SABC 2024 long-term Natali data, which shows a durable reduction in distance recurrence-free survival in the hormone-positive early breast cancer patients. So, despite the improvement in the outcome of the hormone-positive early breast cancer, distance recurrence is the major concern because after the disease being metastatic, there is no cure. We can only increase the overall survival by various measures. In Italy trial, disease-free survival was improved with the addition of ribociclib along with the non-steroidal aromatase inhibitors, especially in stage 2 and stage 3 hormone-positive, HER2-negative early breast cancers, with the hazard ratio benefit at the follow-up of 44 months was 0.7. And the risk of distance recurrence was depended on various features, including the adjuvant treatment, protocols, this and most important one being the stage and the nodal status of the disease. And I'm presenting the disease-free survival and distance recurrence-free survival data for the 4-year landmark analysis. So, coming to the Natali study design, all the patients, other adult patients who were hormone positive, HER2 negative, whether it was a anatomical stage 2A with N0 disease and high-grade features like grade 2 with the Ki67 more than 20%, or oncotype DX more than 26, or high-risk genomic risk profiling, or grade 3, or any N1 disease, all the stage 2B disease, and all anatomical stage 3 disease were included and randomized between 1:1 ratio with the ribociclib 400 mg, 3 week on, 1 week off, for 3 years, along with the letrozole or anastrozole, and goserelin was given in men and premenopausal women, versus only letrozole or anastrozole for 5 years. The primary endpoint was invasive disease-free survival, and we'll be discussing the secondary endpoint, which is distance disease-free survival, and exploratory endpoint, which was distant recurrence-free survival rate in intent to treat population. So distance recurrence in the intent to treat population at the follow-up cutoff of April 2024 and follow-up of 44 months was showing a DDFS benefit, distance disease-free survival benefit, with the hazard ratio of 0.7, with the p-value being significant, with 9% event in ribociclib arm and 12% incident events in the control arm. And if we talk about the disease recurrence-free survival rate, again, the hazard ratio was 0.705 with the p-value being significant, and the event were 8% versus 10% in intent to treat population. So most common sites for the distance recurrence was bone, which was almost around 5%, followed by liver, it was 2.5, then lung, lymph nodes, and CNS. So distance disease-free survival, if we talk about according to the stage, in stage 2A, the event was 3% versus 7%, and the hazard ratio was significant, which was 0.3. In stage 2B, the event was 7% in the test versus 9% in the control arm, with the hazard ratio of 0.8. In stage 3A, it is hazard ratio is 0.6. Event was 9 versus 12%. In stage 3B, it was 12 versus 20% with the hazard ratio of 0.5 at the cutoff of 4 years. And distance disease-free survival for the stage 3C with the hazard ratio 0.8, it was 19% in both the arms. With the, if we see the absolute benefit at the end of the 4 year of cutoff data, it was 5% in stage 2A. Stage 2B, it was 2.6%, 4.6 in stage 3A, stage 3B, it was 11%, and stage 3C, it was 4.5% of absolute benefit. And according to the nodal status, in N0 disease, event was 7% versus 10% with the hazard ratio 0.6. And in N1 to N3, it was 9% versus 12% with the hazard ratio 0.726. And so again, the absolute benefit at 4 year cutoff was 4% in both N0, N1 to N3, both the subgroups. And distance disease-free survival was regardless, the benefit was seen regardless of the menopausal status, Ki67 being more than 20 or less than 20, age either less than 40 or more than 65, and the prior endocrine therapy was received for only 12 weeks or it was received more than 26 weeks, with almost the absolute difference of 4 to 5% in all the subgroups, and hazard ratio is almost between 0.5 to 0.7 in all the subgroups. So key finding in concluding my slide. So 4 year landmark analysis performed was after at least 1 year of the patient was off the ribociclib, and combination of ribo with the letro or anastrozole constantly reduce the distance recurrence-free survival and disease-free survival rate in high-risk nodal N0 disease and N1 disease as well in hormone-positive HER2-negative breast cancer, DDFS and DRFS, recurrence and disease-free survival distant. Both benefits were seen in the intent to treat population, and it was increased from 3 years to 4 years. And these finding the support that use of the ribociclib along with the combination of aromatase inhibitor in the adjuvant setting may reduce the risk of distance recurrence in the broader population of high-risk patients who are having a hormone positive and HER2-negative early breast cancer. With that, thank you so much. Over to Asim, sir. Thank you.
Thank you, Ankit. It was a wonderful presentation, and as we all have included in our practices ERPR positive angio disease, and that is N1 to N3 disease. Everywhere they have shown the benefit. The magnitude of benefit is little bit varying, but still the benefit is there. So it can be taken up for the in our practice. And thank you very much for that, for your presentation, Ankit. And
Thank you, sir.
and now I would like to move our next speaker, that is Dr. Manoj Mahajan. He is the Director Oncology Services, Senior Consultant Medical Oncology in the Pacific Medical College and Hospital Udaipur. And he will be speaking on Olympia A trial, that is phase 3 trial, which demonstrate the adjuvant olaparib, which improves the overall survival, IDFS and DDFS in the patient with high risk early breast cancer. So Dr. Manoj is my good friend from Udaipur, and he will be speaking on this important topic.
So, am I audible?
Yes, yes, yes.
Yes. Thanks a lot, Dr. Asim, for giving this opportunity. So, wonderful topics, and I'm listening since last 2, 3 topics. Quite interesting. And to take the follow up of the long standing study like Olympia, which I have been allotted to. Can you share the? Can you run the slides, Swarangi? So it's basically
Yes.
Olympia trial follow-up of adjuvant olaparib in patients of BRCA1/2 mutation in the breast cancer. It's a 10-year follow-up study from the first enrollment of the first patient FPI in the Olympia trial in the adjuvant setting. Next slide. So this is the declaration of interest and the academia industry partnerships. Next slide. So coming to the rationale of the study, as we know, the PARP has changed our understanding, especially with the PARP inhibitors, due to synthetic lethality in the patients who have already dysfunctional BRCA1, BRCA2 mutations, where the repair mechanisms are impaired. If we inhibit the PARP, that will result in the better damage to the tumor cells and eventually good survival for the patients. So loss of functional germline pathological variants in BRCA1/2 predisposed to both ER positive and TNBC. So Olympia trial uniquely examined the olaparib in adjuvant setting in patients with the germline BRCA mutation positive, which are known pathogenic variants, and patients who are high risk early HER2 negative breast cancer. So the earlier study, first pre-specified interim analysis and second pre-specified interim analysis showed significantly improved IDFS, DDFS, and OS. So this is the updated analysis at the 10 years from the first patients. So median follow-up is up to 6.1 years, maximum around 9.6 years, and additional 2.6 year follow-up since the previous analysis. Next slide. So coming to the Olympia trial schema, if we look at the overall groups, these were in the 2 groups, germline pathogenic variant or likely pathogenic BRCA1, BRCA2 mutation, HER2 negative, which included ER, PR positive or TNBC, stage 2 and stage 3 breast cancer, and who have lack of PACR2 NSCT. So 2 groups mainly, neoadjuvant group with residual disease irrespective of TNBC or ER/PR positivity. In ER/PR positivity, apart from residual disease or non-PACR, there was one more score, CPS plus EG score, which should be more than 3. For this group, schema was 6 cycles of neoadjuvant chemotherapy, surgery plus minus radiotherapy, and then randomization in 1:1 fashion. For the adjuvant group, TNBC, T2 or node positivity, and for ER/PR again, one more additional fee, less than 3 lymph nodes were excluded, more than 4 lymph nodes were included, where TNBC more than any lymph node positivity is included. So stratification factor mainly an ER/PR positive status versus TNBC, neoadjuvant versus adjuvant, prior platinum-based chemotherapy, yes or no, and concurrent adjuvant therapy, endocrine therapy, bisphosphonate or adjuvant therapy were allowed. So it was randomized, huge number of patients, 1800 patients, 1:1 randomization, olaparib versus placebo for 1 year. Primary endpoint was IDFS, secondary endpoint was where DDFS and OS and BRCA associated cancer. Next slide. So if we look at the patient characteristics, quite well balanced. BRCA1/2 nearly 3/4 of patients positive, Premenopausal, nearly 2/3 patients, 1/3 postmenopausal. Primary breast surgery, mastectomy, 3/4 patients. BCS, around 1/4 patient. Next slide. TNBC constitute majority, almost 80% patients. ERPR, 20% patients. Adjuvant, around in 50%, half of patient. New adjuvant, around 50% patients. Anthracycline and taxane regimen, most of the patient, 94% patients. Neoadjuvant-based, platinum-based chemotherapy, nearly 25% patient. Concurrent endocrine therapy received was in those who are HR positive only, were received in around 86% of the patient. Next slide. So this was the patient characteristics. So if we look at the pool analysis at the end of 10 years, median follow-up of 6.1 years and maximum is around 9.6 years. So IDFS and DDFS significant, p-value 0.005, OS 0.01. So all confidence intervals are 95% CIs and are descriptive. Next slide. So if we look at the first IDFS event, distant recurrence was the commonest one, 11.5%, which was lower as compared to the placebo, which was 16%. Regional recurrence, all other recurrences were comparatively lower as compared to placebo, including local contralateral invasive breast cancer, secondary primary non-breast malignancies were lower in olaparib as compared to the placebo, which was around 4%. Next slide. So if we look at the IDFS in intention to treat population, 6-year IDFS rates, there was difference of 9.4% with hazard ratio of 0.65 with adjuvant olaparib. So it's quite significant. 6-year IDFS has increased as compared to 4-year IDFS was 8.4%. 6-year IDFS is 9.4%. So this delta has increased. Next slide. If we look at the subgroup analysis, so all the groups, adjuvant, neoadjuvant, prior platinum, yes or no, hormone receptor status, BRCA1, 2, all the subgroups benefited from the adjuvant olaparib. Next slide. Is there any difference in hormone receptor status? If we look at the overall median follow-up stratified hazard ratio for triple negative, it was 0.65. And for ER or PR positive, 0.68. Nearly same. But if we look at the delta, it's slightly favoring to the triple negative patients. Next slide. So again, analysis of DDFS, intention to treat population, 6-year DDFS rates, 7.8% as compared to 4-year, 7.5%. Hazard ratio, stratified hazard ratio, 0.65. Again, clinically significant. Next slide. If we dissect down the DDFS with the subgroups, again, all the subgroups benefited with the adjuvant olaparib for 1 year. Next slide. All deaths, if we dissect down the deaths in the intention to treat population, total number of deaths were around 11% in olaparib arm versus 15% in the placebo arm. Primary cause of death was 10% patient breast cancer recurrence versus 14%. So which was again lower as compared to the placebo. Next slide. Analysis of OS, if we look at the OS rate, 6-year OS rates, difference of almost around 4.4%, 83% versus 87%, with the stratified hazard ratio of 0.72. So again, olaparib scores over placebo in this intent to treat analysis subgroup. Next slide. In the subgroup analysis, the only thing where it reaches to unity is around prior use of platinum in the adjuvant olaparib. So this is the OS. Probably this is OS is around 0.97. Hazard ratio p value is 0.19, and for BRCA 2, it was p value of for heterogeneity is 1. So if we look, except use of platinum, probably is equivalent to the use of olaparib, adjuvant olaparib. Rest all other subgroups are favoring to the adjuvant olaparib. But still, this subset analysis is not powered enough to answer this question. Next slide. So summary of adverse events, if we look at the overall adverse event leading to death, less than 1% in the olaparib arm versus again 1.1% in the placebo arm. The very often spoken about is about MDS and ML. AML is around 0.5% in the olaparib arm, which was more than that, numerically more than plus olaparib 0.7%. Pneumonitis was seen in around 1% versus 1.4%. New primary malignancy, again lower as compared to the placebo. Next slide. So if we look at the new primary malignancies, so overall percentage 4.9% versus 7.5. Breast was the commonest one, followed by ovarian tumors and pancreatic tumors, but it was much lower as compared to the placebo. Probably that is inherent nature to the BRCA. Last slide. So summary of new breast ovarian cancers during the follow-up. If we take the bilateral mastectomy prior to randomization, it was 36% in the olaparib and placebo arm, it was 35%. So overall, if we look at the patients with the contralateral invasive breast cancers, again numerically lower in the olaparib arm, even ipsilateral as well as non-invasive cancers were lower with the olaparib arm. Next slide. So number of pregnancies are reported on study pregnancies and outcome. Number of pregnancies almost equal in both the arms, and both the parameters were more or less similar. Next slide. So to conclude, there is definitely 10-year long-term follow-up. There is improvement in the IDFS, DDFS, and OS in patients with the 1-year adjuvant olaparib in germline BRCA pathogenic variant and a high-risk HER2 negative primary breast cancer. And the side effects are no longer more as compared to the placebo, or especially the worry of MDS and AML, which was a long hound worry with the olaparib, has reduced. As per the study, it is much lesser, almost 50% to the extent 50% lesser than the placebo arm. So I think 1-year olaparib can be used in this subset of the patients for the improvement of IDFS, DDFS, as well as OS. Thank you. Thank you.
Thank you, Dr. Manoj. You nicely presented the study, and you very well pointed out that if the patient has been exposed to the platinum, then the benefit is touching to the midline, or that is the line of unity. But you rightly said is that it is not powered to answer this particular question. Other than this particular subgroup, everything is in favor of the this one olaparib, right?
Adjuvant olaparib, yes.
Adjuvant olaparib. And
Dr. Manoj, Dr. Asim.
yeah, Dr. Jitendra.
Are, namaste, sir.
Namaste, namaste.
So
Good evening,
my
good evening.
question, good evening. Neoadjuvant Pembro, adjuvant capecitabine, olaparib. How to sequence it?
So if the question is not asked in the trial, but if patient is positive to BRCA, so first we will give the chance to this olaparib.
Patient is started on neoadjuvant Pembro, sir.
Then we might continue with the Pembro and olaparib.
So we can give Ola.
Yes.
Because one of my patient has PET CR, so capecitabine is out. And now
Capecitabine is out.
Yes.
it is a PET CR, so nodal status is not there.
No, for
No, early.
in
Early.
neoadjuvant setting, PAT-CRs were excluded in this adjuvant olaparib trial.
That's why.
So,
And as in
so
the subset of
so
the
I think
analysis. Yeah, Manoj.
so I think this question doesn't arise in patients who are having PAT-CR.
And suppose if patient doesn't have a PET CR,
Adjuvant olaparib is given only when there is a residual disease, irrespective of for residual for understanding, residual disease should be there irrespective of TNBC or hormone positive.
Yeah.
So that
In
is what the
individuals, I
trial
think.
included. The post-neoadjuvant residual disease should be there to consider adjuvant olaparib.
Correct. That is thing. Yeah. So, and the other thing, the worry about the MDS and AML, where we had seen like almost 3 cases in both the arm were there with the AML, right? So there is no extra worry about this AML like or MDS like situation with the olaparib. So thank you very much, Dr. Manoj. And now we will move to our next speaker, Dr. Preeti Agrawal. She is the consultant medical oncologist in Apex Hospital, so Narayana Hospital, Jaipur, and she will be speaking on the trial very well taught or very well talked about. This is a Patina trial, a randomized open label phase 3 trial to evaluate the efficacy and safety of Pelbo plus anti-HER2 therapy plus endocrine therapy versus only anti-HER2 therapy plus endocrine therapy after induction treatment for hormone receptor positive, HER2 negative metastatic breast cancer. It's a very important topic, and everyone wants to know that is there any benefit of adding palbociclib to this particular population group. So, Dr. Preeti Agrawal, over to you.
Thank you, sir. Thank you, sir, for giving me this opportunity. I would request organizers to please share my slides. Yeah. Yeah. So this is a Patina study. So this is a phase 3 trial, which is open label randomized to evaluate efficacy and safety of addition of CDK4/6 inhibitor to triple positive metastatic breast cancers after induction chemotherapy. So addition of CDK4/6 versus placebo along with endocrine therapy and anti-HER2 therapy. Next slide, please. So as we all know, almost 15 to 20% patients are of breast cancer express HER2. Out of these, almost 50% patients are triple positive, means they also express ERPR. So we know that anti-HER2 therapy has significantly improved survival, and in metastatic setting, this resistance to therapy remains inevitable. So we try to find the reasons of resistance and cure for this resistance. So one of them is the rationale for blocking CDK4/6 inhibitor, CDK4/6 in HER2 positive disease. Cyclin D1 CDK4 axis is essential for initiation and maintenance of growth of HER2 driven breast cancers. Persistent cyclin D1 CDK4 activity drives resistance in HER2 pathway blockage. So that is why combined use of CDK4/6 and HER2 inhibition might help. And in early preclinical models, it has shown synergistic activity as well. As we know, palbociclib is an approved CDK4/6 inhibitor, and it has improved progression-free survivals in hormone-positive HER2-negative breast cancer. Next slide. With this background, this study was planned, and the rationale I already discussed. Inhibition of CDK4/6 along with cyclin D1 along and HER2 might have synergistic effect because they all, next slide, because they all next slide, yeah, so because they both the HER2 and CDK4/6 pathway converge at tumor suppressor protein TSC2. So next slide. So when there is synergistic inhibition, so there is potent suppression of RB phosphorylation and mTOR activity, which enhances anti-proliferative effects of tumor cells. So both the pathways converge directly to this TSC2 or tumor suppressor gene, uh, and blocking both of them simultaneously might help in potent anti-tumor activity. Next slide. Yeah. So with this background, and patients with triple positive metastatic breast cancer who have not received prior treatment and in metastatic second, and beyond induction chemotherapy. 6 to 8 cycles of induction chemotherapy, including trastuzumab, pertuzumab, or chemotherapy like taxane or vinorelbine was given. Eligibility criteria was completion of chemotherapy, and there is no evidence of progression. Means patients should either be in CR, PR, or stable disease. They were randomized in 2 arms, one with CDK4/6, palbociclib, with HER2 and endocrine therapy, another placebo, HER2, and endocrine therapy. And the treatment was continued until progressive disease or toxicity. And there was stratified, the patients were stratified according to the use of pertuzumab. The prior anti-HER2 therapy the patient received in neoadjuvant or adjuvant setting, and the response of induction chemotherapy, whether it was in CR, PR, or stable disease, and the type of endocrine therapy, whether fulvestrant or AI was given. Next slide, please. So the primary endpoint was investigator-assessed progression-free survival, and the secondary endpoint was overall survival. I'm not going to details of statistics. Next slide. So the study was, enrollment was done from June 2017 to July 21. 496 patients were targeted. Then finally, 518 patients were accrued. The data cutoff was done on October 15 for PFS and December 2 for OS in 2024. Next slide, please. Yeah, this is the consort diagram. 630 patients screened, 518 patients randomized, 261 in palbo arm and 257 in standard arm. Next slide. So these are the key demographic characteristics of the patient. The median age of the patients was 53 years in both the arms. 90% patients were white. 99% patients were females. 1 or 2 patients are male. Male breast cancer were also included. And median 6 cycles of induction chemotherapy plus HER2 therapy was given in both the arms. Next slide. Yeah. Previous slide. Yeah. Pertuzumab was used in almost 97% patients. So that is an important finding. Almost 97% patients were pertuzumab was used in both the arms. And the endocrine therapy was AI in 90% patients in both the arms, and 10% patients received fulvestrant. And in neoadjuvant setting, almost 70% patients had received anti-HER2 therapy. So we can say only 27 to 30% patients were de novo metastatic. And most of the patient, almost 70% patient had either CR or partial response, and 30% patient had stable disease in both the arms. Next slide. So both the arms were equally matched. So this is a progression-free survival, Kaplan-Meier curves. The median progression-free survival with palbociclib, anti-HER2, and endocrine therapy was 44.3 months compared to 29 months, and in which CDK4/6 was not used, with the hazard ratio of 0.74 with a p-value of 0.007. So we can clearly see the separation of graphs, and with almost 10% difference in each year as we go down. And the graphs keep on continue to separate it as we go down. Next slide, please. Yeah. So as we stratify, the advantage of CDK4/6 inhibitor was seen in all the subgroup, whether they received prior anti-HER2 therapy or no prior anti-HER2 therapy. Whatever is the best response to induction chemotherapy, it was seen in all the subgroups, pre-specified subgroups. Next slide. Even the overall response rate was improved from 22% to 29%, and the clinical benefit rate was improved from 81% to 89%. Next slide. The secondary endpoint, which was overall survival, it was not reached in palbociclib arm, while it was median overall survival was 77 months in anti-HER2 and ET arm, in which CDK4/6 was not used. 3-year OS rate was 87% versus 84.7%, while 5-year OS rate was 74.3% versus 69.48%, with a hazard ratio of 0.86 although the confidence interval is very, very wide, 0.6 to 1.24, but the data is yet to mature. Next slide. So these are the adverse events of more than grade 2 in more than 10% patients. As we know that palbociclib causes neutropenia. The grade 3 neutropenia was seen in 63% patients, and fatigue, while it was just 4% in anti-HER2 and endocrine therapy arm. The other side effects are other significant side effects are fatigue, stomatitis, diarrhea, which was seen in almost 10% patients. Next slide. Next slide. Yeah. So the incidence of grade 4 adverse event, it was regardless of attribution and was similar across the study arms. And the treatment related discontinuation was reported in 14 patients, almost 7.5% patients in palbociclib arm, while it was not reported in the no treatment related deaths were reported in either arm. Next slide. So concluding, so these results strongly reinforce that scientific rationale for overcoming resistance to anti-HER2 therapy and endocrine therapy by addition of CDK4/6 inhibitor. The addition of CDK4/6 palbociclib helps in improvement in progression-free survival across all the subgroups, and it has manageable side effects and with no new safety signals. With this, I end it. Thank you so much.
Yeah, thank you, Dr. Preeti, for your
Yeah.
nice presentation. And this is the one study which we can readily enroll in our patient clinics. And it is kind of like next Monday morning, we can start this kind of the approach. Is that right?
Yes, sir.
Yeah. So very nice study. I would like to request you to please stay there because you are the we are the one of the panelists in this next talk. So now for the next this one event, it is moderator is Dr. Ankur Vashni. It is a panel discussion. Dr. Ankur Vashni is working in the Gurugram, and the panelists are Dr. Sudhir Palsania. He is a consultant medical oncologist in Department of Medical Oncology, Shelby Hospital.
Good evening, sir.
Good evening. Dr. Devesh Goyal is senior consultant in Medical Oncology Department, Fortis Hospital, Jaipur. Dr. Jitendra Pehlajani is a consultant medical oncologist in the SCG Hospital, and Dr. Preeti Agrawal, she is the consultant medical oncologist in the Narayana Hospital. So, Dr. Ankur Vashne, over to you, and I would like to make a small request because we are running late by almost 15-17 minutes. So, if you can control your talk or concise your talk for 20 minutes, I guess.
Okay, sir. And
Actually,
very
the
first
topics
thing,
are so new and the important, like we are just say हम खो गए हैं in discussions में, but we need to respect time also. Yeah, thank you. Yeah, you can start now, Dr. Ankur. Somebody can share Dr. Ankur's slide. Swarangi, are you there?
Yes, sir.
Yeah,
So I'm
please,
checking.
please
Yeah.
help him. Yeah.
ये तुम सही कर दोगे मैं आज खेल नहीं पा रहा
कर दो.
Dr. Devesh is joined.
Yes, yes.
Hello, good evening, Dr. Devesh.
Good evening, good evening.
How is the life?
Fine, fine.
Yes, it's the evening time is too tough to be spare for the meetings and all that, you know. Our kids expect us to play with them.
Hmm. I think we can discuss independently without any PPT.
देवेश बॉस कुछ भी डिस्कस कर सकते हैं.
How are you, Jiten?
Dr. Ankur is rejoining. There is some technical glitches, so he just log out.
बॉस को प्रणाम.
How are you? How are you, Jitendra?
बॉस आपकी कृपादर्शी में रह रहे हैं जयपुर में.
Just are you doing all these things, BRCA, as well as this in each and every patient of breast?
सर इस कूपन की दुनिया में चल रहा है काम.
Okay.
हाँ.
Doctor has joined, I think.
Hello.
Yes.
Hello. Am I audible?
Yeah, yeah.
Yes, yes, yes.
There's some technical glitch going on. Okay. So, as we are all medical oncologists, so Ragi, I think you have to share the slides first.
Sure, sir. I will share from
Okay.
my side. Yeah.
So I will start with the very first abstract which was shared for me with the Olympiad trial. And the
Okay, I
very
will share.
first question which goes along with me, the very first thing that the trial has a specific inclusion point for those patients of TNBC who doesn't achieve PET-CR after receiving NACT. So my first question to my first panelist will be, how do you approach in a typical case of an early stage TNBC? Dr. Sudhir, can you answer what is your approach?
For the early stage TNBC, there is a if hello, I'm audible, sir.
Sudhir.
There is a role of neoadjuvant chemotherapy first there, and there is a neoadjuvant immunotherapy now is there for the pembrolizumab. So we will go for the first if there is a tumor size is more than 1 or 1.5 centimeter, we go for the neoadjuvant therapy first, and then we go for the according to the pathological CR or not of the patient. And
so how many of your patients achieve PET-CR?
In the beginning, we start with the germline BRCA testing also for the patient. Sorry.
Okay. So how many of your patients achieve PET-CR?
After this,
with the
inclusion of the immunotherapy, yes, sir.
With the use of neoadjuvant immunotherapy and chemotherapy, what significant percentage achieve PET-CR?
Yes, sir. After the neoadjuvant immunotherapy, there is more than half there the PET-CR are there.
So almost half of the patients are excluded for this study then.
If we use the immunotherapy, not only the chemotherapy.
Okay. And any of medical oncologists will like to take case that in Jaipur, what is the current scenario? Do all the patients of triple negative come for NACT followed by surgery, or the surgeon takes the lead and go for surgery and then send you for adjuvant therapy?
No, sir. If there is around now the scenario is changed. If the node is positive or tumor is more than 2 centimeter, more than 1, but 2 to 3 centimeter more than the surgeons also refer now for the new adjuvant in the TNBC mostly.
So scenario is changing.
Yeah, for the TNBC mostly, and then the HRT also.
Okay. So Dr. Preeti, will you like to take the case that is there any patient, because with the use of neoadjuvant immunotherapy, we are not going to get cases for dose-dense therapy. So is there any patient population where you opt for dose-dense therapy, or you all go for neoadjuvant immunotherapy with chemotherapy in every case?
10 minutes. 10 minutes.
Hello, Dr. Preeti? Dr. Jitendra?
Yeah, Ankur, if you compare the dose dense data with immunochemo data, means the data is stronger for immunochemo. So probably if the patient is affordable for pembro chemo, then that is the way from my side. and I will decide on carboplatin on the basis of BRCA as whether I will be able to add olaparib or not. Meanwhile, 4AC completes, you get a BRCA report on the basis of that. If patient is not feasible for immuno for any reason, whether it is financial or anything, so probably dose dense chemo is the way to go.
Okay. So we completely agree with the concept that definitely if patients is financially fit enough, we go ahead with the neoadjuvant immunochemotherapy. And then with the use of immunochemotherapy, the PET-CR rates have increased at almost 50%. So the lack upfront use of Olympia is not needed in many patients, but definitely the patients who have not received PET-CR and who have not achieved this, who had not received neoadjuvant therapy, are definitely the patient population where this must be used. Now, my next question, anyone will like to opt for, if PET-CR is not achieved and patient is BRCA positive, so what is the choice? You go for Olympia study, you go for CREATEX trial.
I think can go on this Olympia trial, and if the BRCA is positive, so can add olaparib upfrontly.
After nobody wants to take for capcitabine,
I think
adjuvant capcitabine.
no. I think if BRCA positive, so we can add this olaparib. Data is also supporting this. This
Both has given OS benefit.
yeah.
Both is showing a OS benefit. So we're still in
Ankur,
BRCA positive.
usually the discussion goes like, if there is a residual disease which is heavy in burden, then probably PARP inhibitors are better because it's a chemo-resistant disease. If it is not, then probably you can go ahead with capecitabine.
Okay. Okay. So after this, we will move to for the next. There is no doubt that we will definitely take for BRCA patient. We will take for olaparib. So anybody countering the difference between the newer generic versions of olaparib? Are you able to see any side effect specifically?
I think more and more comfortable with this research brand compared to the generic. Generic are more number of side effects compared to the research brand. In dyselectrolytemias, hypomagnesiemias, more number of anemias, neutropenias. So I think the generic brands, I think some things are lacking. I think.
Definitely. And
And
the
sir,
most important side
I
effect, fatigue.
I feel about anemia also, sir. In some my patient, there are the decrease in the HP 2 to 3 points.
Yeah.
With generic around 6, 7 HP is there
Yes.
of the 10, 11.
Okay. And has anybody seen cases pertaining to conversion to MDS or AML with the use of more than 1 year of olaparib?
I think in one of my patient in ovarian cancer, I have just observed the after the giving the ovarian cancer BRCA positive. So in that scenario, the patient converted to the AML.
So definitely, we are agree with the Olympia data that the patients who are BRCA positive and had either persistent disease with chemotherapy should be offered olaparib. But then we do face challenges with increased risk of side effect as well as the most threatening risk, which is the development of AML and MDS.
Also,
And
but
so,
I feel, sir, AML and MDS also there before the olaparib also.
yeah.
I see some patient with the ACA regimen, they also develop AML.
Yeah, but the
Like
incidence
previous
has
board said, one
definitely
patient,
increased.
1 to 2 patient per year, there are the common scenario in the breast cancer because
Okay.
of longer survival.
Okay, so now we move to next study, which is the Patina study Dr. Preeti just presented, which included the patients with HR positive and HER2 positive to receive HER2 based dual anti HER2 blockade with taxane, followed by randomization to receive palbociclib with endocrine therapy along with dual anti HER2. And definitely, we have seen significant data that was presented by Dr. Preeti that this has shown a clear-cut PFS advantage. So, in your practice, what is the current scenario? Are you still using the dual anti-HER2 or using the single anti-HER2 agent? Dr. Devesh.
I think in triple positive metastatic, I am just using single agent this anti-HER2 trastuzumab along with this endocrine therapy. I think
Okay.
FERT I have not added even this time. I think just only single agent I am giving.
Okay. So any specific reasons
I
or
think we can.
matlab the
No specific reason. I think we can add this the PER2.
okay.
I think the triple positive are compared to this ERPR negative are less aggressive
Mhm.
biology. I think we can
Mhm.
continue with the single agent.
Okay. And Jiten sir, what is your approach? Just let us move ahead. If the patient is only HER positive and patient has started with dual anti-HER2 new, achieve PET CR. So what do you follow in adjuvant setting? I do continue with dual or therapy, or you go for a single agent trastuzumab?
Ankur, it means you have to continue dual anti-HER2.
You do have to continue dual anti-HER2 new. Okay. And in hormone positive setting, if this patient was hormone positive, it started on dual anti-HER2 new, and patient has achieved PET-CR, now presented to you for adjuvant therapy. So what will be your adjuvant choice?
Dual anti-HER2 with probably AI, if feasible OFS plus AI.
Okay. And now will you be considering a change with the use with this patina study coming on?
See, now there are many things which we can do in HER2 space. We have to see first the DFS. See,
Okay.
in Patina also, you have patients who had 80% patient had primary anti-HER2 therapy. So we have to
Okay.
see whether that DFS was 6 months, 1 year,
Mhm.
if single anti-HER2 was given earlier, all these things will matter. Everything has to be keep in mind. So still, if patient has not exposed to dual anti-HER2, probably anti-HER2 will favor the patient. If patient has relapsed within 6 to 12 months.
Mm.
More than 12 months, probably it is still sensitive to herceptin or whatever trastuzumab we are giving. But if it is 6 to 12, that is a partially resistant thing. So
Mm.
probably this is the timeline which every trial has used when we were using TDM1, and now in TDXD also similar sort of things have been used. So if patient is 6 to 12 months, I will try to use dual anti-HER2. But my
Mhm.
question here is, if patient is less than 6 months with TDXD data coming up, and if you have given chemotherapy, then probably TDXT versus this, we have to see how it is faring.
Okay. The data will be generating by soon time. So
Yeah, so
everything is
then things will be
changing.
getting
Mhm.
interesting.
Okay. So in the lack of time, we move to the next trial, which is the Natalie study. And I think we are all quite up to data उसका काफी ज़्यादा share हो चुका है. So the very one thing, the very first question I will ask you all, who have changed your practice? So are you still bringing Natalie to your practice in this N0 with additional risk factors cohort? Definitely, N2 and 3 disease, we have been using abemaciclib since long, and definitely we are comfortable with ribociclib. But this early disease with N0 and N1, how many of you are using CD46 inhibitors as an adjuvant?
So there is data for the node negative also, but we mostly use with the node positive patients. N1 also, so there is the
Hmm,
benefit is there. No? With the
definitely. Hmm.
N0 is also there, but mostly we use in the node positive.
So you are any node positive patient, we are offering this now, and
Yeah, we can counsel the
N0,
patient. Yeah,
yeah,
after
N0,
counseling of the patient.
definitely. Because I think PEP
N0
is
is
still not
still,
available. So
yeah,
financial will be always an issue in this condition.
yeah. In N0 there is also benefit, but
Mm. So
uh,
basically, they want to have every patient with HR positive, you should
yeah,
give it. It is the
yeah.
situation is like getting this.
Mm.
Okay. So now we move to the last abstract in this value of time. And I think medical oncologist now will discuss the surgical aspect, whether to go for a sentinel lymph node biopsy or not. So, Dr. Devesh sir, how do you take this surgical study? Are
I
you
think
comfortable in not doing sentinel lymph node biopsy in patients who are clinically node negative?
I think every time there is clinically node negative disease cannot be node positive. So I think sentinel lymph node biopsy is required in my view because
Yeah, I
sometimes
do, and I do consider the same unless the patient is a 70-year-old female
yeah
with limited life expectancy, and we do not want to increase the any toxicity pertaining to it, or a patient with a severe comorbidities like diabetes, low ejection fraction, then we can restrict it. But I think in every young patient or every patient, we should consider this first, because the
Correct.
role of sentinel lymph node is only in the patient with clinical node negative.
Yes.
Anybody will like to differ on this aspect?
No, sir, we go for the sentinel lymph node biopsy because in the 7th year also we get the anesthesia and we fitness
Yeah.
is there for the patient. Then the surgery is there. Then the SLNB is a small thing in front of surgery, like MRM.
Hmm.
MRM तो करना पड़ेगा ना sir.
Yeah, नहीं, in case
MRM,
मतलब we have a
BCS, very
patient who
BCS,
is fragile
BCS.
enough and
Yes,
not
sir.
having a very good life expectancy, in that setting we can recover it.
I
So
think
probably, Ankur, to summarize it, T1, T2 luminal A disease more than 65 can
Hmm.
be gave away.
Can be definitely considered
Yeah.
for
Can
it.
be luminal A. Probably we can go away the lymph node dissection part.
yeah,
Yeah. So
very
okay,
very
I
well
think.
said,
Hmm.
Dr. Jitendra. Very well said.
Hmm. So I think that's 15 minutes already done. So I take my leave
Yeah.
and over back to Asim sir for further thing.
Yeah, thank you, Dr. Ankur.
Thank you, Doctor.
And thank you for all the panelists for a very good discussion.
Yeah, thank you, Dr. Ankur, for nicely conducting this panel discussion. And all the four trials you have summarized in a very good manner. And as Dr. One thing I liked, like Dr. Sudhir has said, like many patients have some MDSI component, uh, especially the older age group, or those who have been exposed to the anthracyclines. So may not be they are the olaparib is responsible for that. And the last when you were discussing about the need of the sentinel lymph node biopsy, which Dr. Jitendra has summarized, like the patient is age more than 65 years, very low risk, grade 1 or 2 only, and hormone receptor positive, HER2 negative. These patients can be spare of the having the lymph node dissection because they have some morbidity effect. So this is the crux of this particular discussion. So thank you, Dr. Jitendra. Thank you, Dr. Devesh and Dr. Sudhir and Dr. Ankur. So now we will move towards the next talk, and this is for this I will call Dr. Jitendra Pahlajani. He is a consultant medical oncologist at SCG Cancer Hospital, Jaipur, and he is the very good friend of us, and he is the very short examiner for our student also. So he will be speaking on maximizing chance of cure in the EBC, early breast cancer. So over to you, Dr. Jitendra.
Thank you, Asim Boss, for the opportunity and Raj for the platform. So this is regarding the HER2 positive breast cancer, like how to maximize the chances of cure in early breast cancer setting. So as we all know that as the more early we treat the patients, the more better are the outcomes. So that's why probably hitting hard on the first go is the best thing. Next slide. So as we all know that HER2, this is a disclaimer, this is the Roche manufacturer slide, and they don't promote the use of medication manufactured by it and in off-label indication. Next slide. So the EBC, the treatment of EBC goal is primarily to cure, and patient should be given the most efficacious treatment available. 78% of metastatic breast cancer cases are due to early breast cancer relapse. And breast cancer recurrences have significant impact on quality of life, and they are usually not salvageable or curable in the metastatic or recurrent setting. Next slide. So the biology of breast cancer is complex. Each patient is different. So HER2 positive disease can be HER2 low, intermediate, as we all know. That HER2 space has changed a lot. It can be luminal type cancer or HER2 negative. Next slide. And then there can be very much other signature on DNA, RNA platform, on protein expression, like BRCA positive, BRCA negative, HRR positive, HRR negative. Next slide. So it's a complex disease. And it also depends on the microenvironment, which we are talking from last decade, but probably we are not still find out how to use best of the microenvironment information in our use. Next slide. So why we are giving neoadjuvant therapy? It increases the BCS rate. It reduces the complication of surgery by reducing the incision. It reduces the need for revision for residual tumor, which probably is now very less with the advent of frozen sections. Treatment of choice for inflammatory and inoperable breast cancer, which are LABC, where we use the neoadjuvant first. And now we can assess the pathological CR, which is the primary goal which we are trying to thrive on our therapies and which is the basic target for that. And on the basis of that PCR, we can direct our therapy by assessing the response of the tumor in the body of the patient by giving the plant treatment. Next slide. So, neoadjuvant therapy enables early response assessment like sensitivity of the tumor to the guided treatment what we are having. It enhance surgical options like by downstaging, we can go for BCS, we can avoid axillary dissection, we can decrease surgical morbidity, and we can allow the time for reconstruction. And one more important thing that you can get the genetic data for planning your treatment better by giving neoadjuvant chemotherapy. Like if patient is BRCA positive, now we have enough data that suggests that if you do a positive mastectomy in those patients, there is an overall survival advantage. So probably in my view, if patient is BRCA positive, we should not do the BCS. Probably we can reconstruct the breast later in the line. And it can give the early treatment to micrometastasis. Next slide. So this is the outcome of neoadjuvant therapy are evaluated by sample taken at the time of surgery. At the primary site, there can be a no disease at the primary site. There probably can be a DCIS. There can be a residual disease. There can be a disease at the lymph node. So by definition, there should be no disease at the primary site as well as the nodal site. That is the ideal way of pathological CR. Next slide. So coming to the first study of dual anti-HER2, the news for study, it was a phase 2 study of pertuzumab and trastuzumab along with chemotherapy. Here we had four arm, Herceptin plus docetaxel, Herceptin plus docetaxel plus pertuzumab with Herceptin, pertuzumab with docetaxel. Then the patient underwent surgery after 4 cycles of chemotherapy. Then patient had the Herceptin plus FEC. So here we can see it's probably was a sandwich regimen which was used. Next slide. And here we can see that pathological response rate was best when we are with pertuzumab, docetaxel, and trastuzumab. The point to be noted here that pertuzumab, docetaxel was even inferior to Herceptin. So if you have to give a single HER2, probably Herceptin is still the best option. Next slide. And these are the 5-year follow-up analysis. As we can see that 5-year PFS was 81% in Taxol, Herceptin, 86% in Taxol, Herceptin, and pertuzumab. And if we see that Taxol and trastuzumab, it was 73%, and pertuzumab with Herceptin, it was 73%. So we all know that if you are supposed to give anti-HER2, dual anti-HER2 is better in the neoadjuvant setting. Next slide. This is the DFS 5 analysis and it shows almost similar results. Next slide. So the summary of the trial was that patch CR rate was around 45% if you give only 4 cycles because FEC was given later. Substantial anti-tumor activity and a favorable therapeutic ratio for pertuzumab and trastuzumab doublet without chemotherapy. If you want to avoid chemotherapy, then probably combination is a go. Pertuzumab and trastuzumab without chemotherapy also eradicate tumor in a considerable percentage of patients. No meaningful increase in cardiac risk with pertuzumab over a short course of 4 cycles. So there was some extrapolation of this study of dual HER2 blockage. Next slide. So this is a trifina study. It was a phase 2 study where the cardiotoxicity was assessed with Perjeta and Herceptin in the neoadjuvant setting along with FEC and docetaxel. So this was a 3-arm study, and here the third arm was without the anthracycline. The second arm was with both FEC docetaxel and Perjeta herceptin. Basically, the Perjeta herceptin was given only with the docetaxel, and in the arm A, it was given along with the FEC. Next slide. So the trial arm was this was a phase two study was the cardiac safety, and the trial was the trial arm was almost well balanced, and we can see here that the cardiotoxicity was similar, almost 5 to 10% variability in various parameters what we can measure in the LV ejection fraction. So all the combination were uh, cardio safe or almost similar cardiotoxicity profile. Next slide. So here comes the PET-CR rate. So PET-CR rate was, if we see that YP2 T2N0, it was on the tune of 51%. If you give PTHTC 6 cycle, which is the primary regime to go, but if you give FEC plus pertuzumab herceptin, it was around 50%. So there was no much difference between them. But if you are giving less pertuzumab trastuzumab by avoiding it with anthracycline, probably we are losing that efficacy. This is what we discussed in other day when we were discussing the dual anti-HER2. So probably we can go away with the anthracycline, and by giving 6 cycle of PTCH regimen, we can achieve the maximum response rate. Next slide. So this is the DFS survival, and all the curves are well matched. The 3-year maximum DFS was PHTC 6 cycle was around 90%. Other was 88% and 87%. Next slide. And overall survival was also similar in all the three arms. Next slide. So now the HER2 positive EBC, probably pertuzumab trastuzumab plus chemotherapy is near-gen standard of choice. Obviously, MDT has to take place, that which patient should receive what. And if any tumor is 2 centimeter or more, even if very young patient, if it is more than 1 centimeter, we can go with probably a single agent anti-HER2 therapy. Chemotherapy 4 to 6 cycle pertuzumab trastuzumab. Then surgery, if you achieve a PET-CR, you continue the same regimen what you have used in the neoadjuvant setting. If there is a residual disease, probably TDM1 is there. If size is T1, means it is less than 2 centimeter. Surgery, if it is node positive, you can give pertuzumab, trastuzumab based regimen if it's a heavy nodal burden disease, more than 4 nodes are positive, which will we see the affinity data in the coming slide. Next slide. So optimal therapy, as we all know, that you can continue the same regimen, whatever is given in the neoadjuvant setting. And those individuals with PCR clearly have cancer sensitive to trastuzumab pertuzumab based therapy. And there is a limited data with shorter duration of trastuzumab pertuzumab, and with the therapy cost coming down by various PAP, probably we can do away the 1 year trastuzumab pertuzumab therapy. Next slide. So this is the adjuvant affinity 10-year update. That adjuvant pertuzumab trastuzumab in EBC positive patient. The overall survival data was presented at 10-year update. The median follow-up was 8.4%. Next slide. So this is the affinity which everybody knows, that almost 5,000 patients were taken. Chemo in the adjuvant setting, patient was randomized 8 weeks within the surgery, chemo plus Perjeta plus Herceptin versus chemo plus Herceptin and placebo. The primary endpoint was IDFS. Next slide. Next slide. So if you see IDFS data, the primary endpoint at 3 years, the difference was 94% versus 93%. At 6 years, it was delta was increased from 0.9% to plus 2.8%. And at 8 years, it stands 2.6%. So overall data had around delta of 2.6% after the follow-up of 8.4 years. And the long-term IDFS benefit was around 24% risk reduction with delta of 2.8%. Next slide. And these are the category of IDFism and distant recurrence. Local was the most common. Local renal recurrence was lesser. Congenital disease was lesser in the both the arm. Next slide. This is a descriptive data that the difference in distant recurrence events between the treatment arm was 1.8% in the delta, means that distal recurrence were more the patient who were not exposed to the pertuzumab. The incidence of CNS metastasis was similar in both the arms. Next slide. And this is the 3-1A descriptive analysis that after a median follow-up, the distance recurrence between the IDFS was 2.3%. With fever distant recurrence is in the dual anti-HER2 arm. Incidence of CNS metastasis was 2.1% versus 2.2%. The other sites were lung, liver, pleural effusion, and bone. Next slide. So this is the difference. The long-term benefit was at a tune of 2.3%, as we all know, and it was independent of the hormone receptor status. Next slide. Next slide. So this is the third pre-planned OS after a median follow-up of 8.5%. The overall survival is not significant if you see the overall population, but it was favoring in the favor of patient who had node positive disease in the pertuzumab cohort. Next slide. So numerically fewer deaths were seen in the pertuzumab Herceptin arm versus the placebo Herceptin arm. The HR, although the confidence interval was 1 in all the subgroup analysis, but the hazard also was less than 1, and the hazard ratio was 0.8 in the node positive setting in these cases. Next slide. So coming to the effective summary, at the third interim analysis, after a median follow-up of 8.54 years, the treatment benefit with Perjepta Herceptin was maintained, 23% risk reduction with the delta of 2.6%, and the IDFS rate was 88.4% with the patient who were receiving dual blockage. The node positive subgroup continued to drive a clear IDFS benefit with the hazard ratio was of 4.9% at 8 years. Next slide. Coming to the safety data, next slide. And there were 3 additional primary cardiac events were seen after the second interim analysis, and the cardiac events remained very low, which were less than 1% in each treatment arm. So there were no new cardiac safety signal were seen in the this trial. Next slide. So probably here also we can see that cardiotoxicity was more when we were using anthracycline. That's why I told that probably PTCHP as a neoadjuvant regimen is more safer and probably it is less cardiotoxic. Next slide. So the safety summary says that incidence of primary cardiac events remains low, which was less than 1%. The heart failure events were more frequent in patients receiving anthracycline chemotherapy, and the incidence of fatal AE remained low as less than 1%, less than 1.5% in each arm. Next slide. So this is the Peony trial where there was a dual anti-HER2 was given along with docetaxel, and it was a neoadjuvant setting. And this study was there as a sandwich study where they have given 4 cycle of neoadjuvant pertuzumab trastuzumab along with docetaxel versus placebo trastuzumab docetaxel, followed by surgery, followed by FEC 3 cycle alone, and then adjuvant pertuzumab trastuzumab versus trastuzumab. Next slide. So in the Pioneer study, this showed us that the 3-year EFS rate was beneficial by almost 9% at 3 years, and uh, at 5 years it was beneficial at the tune of 11%. Next slide. So this was the OS, and we can see that 6% OS benefit was seen if you give neoadjuvant as well as adjuvant pertuzumab trastuzumab at 3 years. But there was 3-year benefit, 3% benefit in overall survival at 5 years. Next slide. So there was similar incidence of serious grade 3 and 4 side effect was seen. So there was there was no new safety signal, and probably diarrhea was more common and URTA were more common in both the subgroup. Next slide. So 5 year survival, the long-term efficacy endpoint EFS and DFS were clinically meaningful with neoadjuvant and adjuvant pertuzumab trastuzumab. The safety data was similar, and probably Punitil adds totally to the data of reinforcing of the dual HER2 blockage in neoadjuvant setting. Next slide. So coming to the recent preparation, not we can not say recent. It is almost 1.5 year in the market. The Phesgo, which is subcutaneous fixed dose dual anti-HER2 therapy, and it contains the same antibodies which was approved for pertuzumab and trastuzumab, but has a different route of administration. It was recombinant human hydrogenase to allow subcutaneous administration of higher dose volumes, and the loading dose of 15 ml and the maintenance dose of 10 ml. It's a ready to use fixed dose combination administered by a subcutaneous injection, and everyone know that it can be given by 5 to 8 minutes, and after that you have to wait for almost half an hour and the patient is fit to go. So probably it is a time saving, and the less calculations are needed because you are not supposed to monitor the patient weight, and it is easy to administer. Next slide. So this is the mechanism of action of pertuzumab and trastuzumab. Probably everybody knows that both bind into the different dimers and inhibit the dimerization. And if both are given, there is a synergistic effect. We all know that hydrogenase is an enzyme which basically cleaves the endoglycosides and increase the dispersion of the drugs when administered subcutaneously. Next slide. So there are two studies. One is a Federica study, which was a phase 3 non-inferiority study by assessing the PK, efficacy, and safety of the pertuzumab, trastuzumab fixed dose subcut versus the pertuzumab, trastuzumab IV. So here the chemotherapy arm were by as per the investigator choice, and patient received the pertuzumab, trastuzumab IV, followed by in one arm, followed by surgery, and in another arm, patient was received the subcut preparation along with docetaxel for surgery. Next slide. So here we can see that the suffix dose subcut arm was not inferior to the IV arm, as well as in the patient serum, in the pertuzumab level, as well as on the trastuzumab level, when we saw the per protocol PK studies in the patient. Next slide. And coming to the CR rate was also similar in all the subgroup, and it was non-inferior to the IV preparation. Next slide. The safety profile was almost similar, and the treatment discontinuation rate was also similar in the both subgroup. Next slide. So the fixed dose subcut combination was non-inferior to the IV therapy pre-dose by cycle 8. The PET-CR rate was also similar in both the arms, and the safety profile was also comparable. So thus the trial was positive, and it was achieved that non-inferiority of the fixed dose combination. Next slide. So this is a Francesca study where they tried to assess how the patient preferred the IV preparation or the subcut preparation, because 15 ml or 10 ml given subcut can be troublesome to somebody, or it is a basically technically driven. You have to train your nursing to give it on the optimum basis. So the primary objective was the patient preference. So they have given 3 cycle IV followed by fixed dose, and they have given in the another arm fixed dose for 3 cycle and 3 cycle IV, and the patient selected whether they want fixed dose or they want IV for the next 12 cycles. Next slide. So here we can see that patient preference was fixed dose at the tune of 85%. So main reason for subcute preparation was that the patient had to wait less time in the clinic, because if you give IV trastuzumab, pertuzumab, it will take at least 2 to 2.5 hours, and the administration was more comfortable. They can move along after half an hour or an hour, and thus the 87% patient chooses the subcute preparation. Next slide. So patients were more satisfied in the subcute preparation, 88% versus 68% in the IV population. Next slide. So coming to the time, as I was discussing, that 30 minutes you can prepare the drug and administer. On the contrary, the administration of IV pertuzumab and trastuzumab was almost 2 hours to 3 hours, not 300 minutes, I can say. And preparing the IV preparation takes almost 20 minutes. So 88% of the patient thought that it was the subcute regimen was the quickest. It requires less resource uses, and it resulted in a less drug wastage. As we all know, it is a fixed dose combination. There is less chances of saving the drug, keeping the vial for the next time. So these all hassles are decreased for the patient as well as of the primary care physician. Next slide. So probably this was the last slide. Uh, So patient satisfaction was more, and patient were able to spend more time in the clinic because they were having less hurry, and it was safe because there was no new safety signal. So probably dual anti-HER2 blockage for neoadjuvant therapy is the best thing which we can do, and probably all of us try to do with the dual anti-HER2 blockage. So this is it. Thank you so much for the time.
Thank you, Dr. Jitendra, for a nice talk. And now I would like to invite my dear colleague, Dr. Bhavesh Palodia. He will be speaking on role of trastuzumab deruxtecan in HER2 positive tumors, and he is the consultant medical oncologist in the Thangam Cancer Center, Namakkal, Tamil Nadu. Yeah, Dr. Bhavesh.
Yes, thank you, Dr. Asim. Can I just share my slide? Right. So thank you, Dr. Asim, for the invite, and thank you, the Horizon team, for making this successful. As Dr. Asim said, we'll be discussing about the role of trastuzumab deruxtecan, which is one of the most popular and the most powerful medicine in anti-HER2 subsite. If we say not only in breast cancer, but in multiple subsites where HER2 expression tumors are there, trastuzumab deruxtecan is causing waves and showing excellent responses. So this is one of the most powerful drug in this anti-HER2 armamentarium if we concentrate on its power. So let us see where all we can use it, especially in the breast cancer, because this is a breast cancer session. And let us understand how to use it and how to take care and how to monitor the safety things. So basic agenda will be to first speak about the trastuzumab deruxtecan in the MBC setting, and followed by that in HER2 low and its clinical implication. This is something new entity which we have to tap, and we can use trastuzumab deruxtecan and an extra armamentarium, a very strong armamentarium in this subsite, and followed by the last summary slide. So in HER2, first we have to understand why it is so powerful. So the making itself is very indigenous, and it is a component. It is a ADC, antibody drug conjugate, which combines trastuzumab with topoisomerase 1 inhibitor, which is a chemotherapy payload. With a this both are joined together by a cleavable linker. The potency of the payload or the chemotherapy itself is very high. The DAR, or also called as a drug to antibody ratio, is 1:8, which is more powerful than even TDM1. Moreover, this payload has a short systemic half-life, so it causes its effect and decreases the side effect. Tumor selective cleavable linker. Again, this is one more important property of the cleavable linker, where it goes into the tumor and then cleaves. And of course, once the tumor cell is killed, the remaining chemotherapy goes and attacks the nearby tumor cell, which is also called as a bystander anti-tumor effect. So this is what is the same thing what I discussed in the pictorial diagram. First, it attaches to the surface of the cell, then it gets internalized, then the cleavable linker separates the trastuzumab and the payload, and the payload enters into the tumor nucleus and kills it. The cell is killed, and then once it is permeable and it goes to the another cell, we also see the bystander side effect. So because of this powerful action, TDX or trastuzumab deruxtecan has demonstrated an excellent response to the therapy, almost to the tune of 61% of patients who were even treated previously with anti-HER2 agent in MBC setting. So this is one of the important area where it has claimed its position in second line of MBC, and this is by the Destiny Breast 03, which is a study for second line of anti-HER2 MBCs who have already progressed on trastuzumab and taxane-based therapies. This also included patients who were clinically stable, treated for brain metastasis, and it had various stratifications like hormone receptor, prior use of pertuzumab, and also a history of visceral disease. So a simple study design, 1:1, to receive TDM1, which was that time the second line standard of care, versus TDX at 5.4 milligram per kg every 3 weeks, with the primary endpoint of PFS. So as we can see from this, uh, the demographic shows that this is something very typical to what we see in our private practice of 50% of HR positive in HER2 positive subsite in a subtype. 15% had brain mets. 70%, this is a big time, big area. 70% who had visceral metastasis. So these are very difficult to treat patients. 61% had prior pertuzumab, which actually in Indian scenario is yet to happen in any of the centers, except where there is a third party payment like railways, etc. You can see that very high usage of pertuzumab, and median 2 lines of prior therapy. So this is practically, actually speaking, third line, but at least second line. And there was a good post-trial setting. If you see, there was a good crossover, TDX receiving TDM1 and TDM1 patient receiving TDS after the progression. And this has led to an excellent PFS. As you can see from the first graph, the PFS has markedly started differing as early as first 2 to 3 months, and it has remained separated for a long time, almost 3 years plus. And it is not only showing difference, it is actually doubling the PFS. And if you see the gap at particular absolute area, but if you see the actual months, then it is almost 4.5 times of TDM1. So TDM1 is close to 7 months, whereas TDX is touching almost 30 months. So this is a huge difference which can be seen with the use of trastuzumab deruxtecan. And coming to the secondary endpoint, which was overall survival. Again, a similar kind of a graph started separating as early as first 1 or 2 months, and showing a persistent 8 to 10% difference at 1 year and 2 year mark. And as of now, they have not come up with any of the medians of both the arms. We are always interested in these two subgroups, which is elderly age group, because we have a good number of elderly group in India now, and also patient with brain metastasis, because this is one of the tumor which spreads to the brain very, very fast. So if we go through this descriptive efficacy according to the age for TDX, we can see that whether it is Destiny Breast 01, 02, or 03, all of them show that patients who are less than 65 or more than 65, they derive good benefit from the use of TDX. And if we see even the PFS as well as the OS, both are equally good. Even the bar diagram, if you see at the 12-month landmark of the overall survival in all the three trials, were equally good. So it does not mean that you can use only in younger patient, you can also use it in older patients. So this is again a comparison of TDX versus TPC, that is a treatment of choice by physician, and TDM1. So this is a combined of Destiny 1, 2, and 3, Destiny Breast 0, 1, 2, 0, 1, 0, 2, and 0, 3. Again, it shows that patients who are young, less than 65 or more than 65, or even very elderly age group of more than 75, they are deriving good benefit with the use of TDX, and it is quite safe to use TDX in these patients. Coming to the specific brain metastasis, if we as we know that it included many of them included even treated stable brain mets and even untreated active brain mets. So if we see, the difference is quite impressive. The PFS is improved by 4 months with the use of TDX in patients who are having treated or stable brain mets. And those who have untreated or active brain mets, they have excellent benefit with the use of TDX. The curve is very, very far apart. 4 months versus close to 19 months. Coming to the change or difference in the size of the tumor and improvement in the tumor, as you can see, if we see to any of the comparator arm of the TDX, that is either TDM1 or Trust Cape or Lab Cape, which we usually use it in our practice, it is giving a partial response to less than 50% of the patient. Whereas in TDX, if we see, almost 75% of the patient are having partial response, and there are 0% patients who are actually progressing or having progressive disease more than 20%. Similarly, these are all small studies, but having good results to discuss. This is Tuxedo 1 and Rosette brain metastasis retrospective study, where again this waterfall plot shows an excellent intracranial response, close to 75%. So this was the power of the TDX in MBC in HER2. And now we see the same, but in a HER2 low setting. So first we have to understand why HER2 low is so important, because conventionally we know that HER2 positive is IHC 3 plus or IHC 2 plus with FISH positive. All of them, excluding all those 15%, we used to consider the remaining 85% as HER2 negative. But in that subset of HER2 negative, there is a subsection called as HER2 low, where you consider patients having HER2 IHC of HER2 2 plus but FISH negative, and also patients who are having HER2 IHC 1 plus. So except for patients who are having HER2 0, we include those patients as HER2 low. And obviously, there were initially some challenges because this is not the routine thing we used to do. But since last 1 year, the pathologists are getting accustomed to give this report, especially when they are asked for. And this is slowly becoming a group where we can use this important therapy. So here you can see there is a specific dose forming study where they showed that 5.4 or 6.4 both showed equally good effect in the patients having HER2 low breast cancer. As you can see, the waterfall plot and the spider plot. And not only that, even in patients who are having hormone positivity, IHC 2 plus or 1 plus, everybody is deriving a benefit of close to 35 to 45%. Coming to this specific trial, which is Destiny Breast 04, this is an important trial which actually showed the use of or the power of TDX versus the TPC, that is a physician's choice treatment in this specific subtype of HER2 low, where they included patients who have progressed on 1 to 2 prior lines of chemotherapy. And suppose if patients were hormone positive, they should have become endocrine refractory. So these are very difficult to treat patient. We also know that in practice, once the hormone positive becomes endocrine refractory, it is very, very difficult to treat these patients. So in this patient, they were randomized 2:1 to receive TDX versus the standard of care by the physicians. And the endpoint was PFS again. So we can see that the PFS in hormone positive or in entire population was impressive. It has improved the PFS by at least 4.5 to 5 months. This was updated progression-free survival, and again this shows similar benefit. It has not decreased over the period of time, but it has maintained over the period of time in both the subgroups of HR positive or all patients. Coming to the overall survival, again, it is quite, it is showing similar benefit. It was showing a benefit of 6 to 7 months, and this has been persistent in both hormone positive as well as in the entire population. This is specifically for HR negative subgroup, or we can typically say the way we used to treat TNBCs previously. So this is one of the, if the TNBC comes out to be a low, HER2 low subtype, then this can again show wonder. And if we see the PFS advantage is again similar to what we saw for the HR positive, and there is a difference of more than 5 months, and the OS has improved by almost 10 months. Coming to the adverse events, luckily the adverse events have not been very bad. If we include both TDX and the TDX in any of the trials, and there has, in this specific trial, there has been no grade 4 and grade 5 except for one patient, which actually had to suffer. There were a couple of patients which had to suffer grade 5 because of mainly because of interstitial lung disease. Coming to the specific IHC1 and IHC2 to separate and see whether there was a specific difference. So this waterfall plot as well as the forest plot shows that there was benefit in both the subgroups, whether it is IHC1 plus or patients with 2 plus IHC and ISH negative. Coming to further subset analysis, you can see each and every subset, whether patient having hormone positive prior CDK4/6 inhibitor, irrespective of the disease burden, low or high, HER2 status of IHC1 and 2 already we saw, in the prior lines of therapy, age, etc. Everybody has had a good PFS, good overall response rate, and even the safety profile, if we see prior use of CDK4/6 or not, low disease or high disease burden, everybody is getting deriving a good benefit with the use of TDX. This is something, a phenomenon which we see, that there is a dynamic expression of HER2 which may change from early to late stage. And if we consider all case, there are certain patients who are to begin with, suppose they are HER2 low, they may become HER2 zero and vice versa. Same thing can happen in both HR positive and TNBCs also. But if we see the survival curves, there is no difference between the HER2 low or zero in the primary, if we see in the primary tumor. This is actually a cross check with the historical result, and they showed that if we see the previous historical result and the current one, according to the pathway HER2 4B5 assay, there is a concordance of 78%, which says that HER2 low were HER2 low, and the remaining 22%, majority of them actually scored IHC 0. Whereas 12%, a small percentage, actually had IHC2-ish positive or IHC3 plus. So actually these patients were wrongly labeled as HER2 low, and they were actually deserving to get a anti-HER2 agent therapy. So this is something also we have to keep it in mind, whether if we can get a a HER2 dual IHC DNA probe where we can pick up these 12% patients. Coming to the side effects, which is the most dreaded side effect we are all worried about, because this is so bad that as soon as the patient goes into a grade 2 kind of interstitial lung disease, we stop the drug. We don't continue the drug further. So this is one of the dreaded disease where we, first of all, do not want it to come. We can just pray for it. But if it comes, we see to it that we keep our eyes, mind, ear, brain, everything open to detect it early and prevent it to go from grade 1 and above. So I'll not go into the detail of this in interest of time, but we know that how to monitor it. Very close monitoring is required. Patient education is required. As soon as you doubt it, confirm your diagnosis. Dose interruption is necessary, followed by immediate starting of corticosteroid therapy, and look for the resolution of the symptoms. Early resolution is a good sign. We can restart, but if there is a late resolution, we have to go down by one level dose. But if it is not improving, or if it is going to grade 2 and above, we usually stop the drug. We do not continue it further. So this is the same thing, repeat of the same thing. So I'm not going to the detail of this. So what we understand that HER2 expression tumor are very special now, because we have a very powerful agent like TDX, and it has a very powerful effect on the patients who are MBC HER2 positive, MBC with HER2 low. And we have seen with Destiny Breast 03 and 04, there is a very good improvement in the PFS, and the OS is also very promising. So this becomes one of the choices, which is it is already competing, already established in second line and above. Now it is competing actually for first line versus the Cleopatra. It is also fighting with TDM1 in the adjuvant setting, and also in TCHP in the neoadjuvant setting. So I think the results should be announced, at least one of them in this ASCO. So let's hope. I am very positive for this results, and these are going to be very powerful results for the TDX and for the AstraZeneca. So I'll stop here, and thank you for the opportunity.
Thank you, Dr. Bhavesh, for your wonderful talk. And now, in the interest of time, we'll move for the further topic. But yes, you have highlighted that in the HER2 positive tumor is a dynamic marker, and in the 12% of the cases, they might be positive for the later on therapy, later on in the treatment journey. So there should be some more sensitive probes, right? So
Yes.
the time will come when we'll be having like HER2 negative, then HER2 low positive, ultra low positive, and then positive and clear positive, right? So these kind
Yes.
of approaches, they are just emerging, and everybody is following this particular drug because we had seen the response in our clinical practice. So thank you very much, Dr. Bhavesh, for enlightening us. And now I will move to Dr. Sandeep Bhaskar. He is a medical oncologist in the RHL Hospital, Jaipur, and he will be speaking on the response guided approach in the HER2 positive early breast cancer, fueled with the updated data on the TDM1. So, Dr. Sandeep, over to you. And Dr. Bhavish, thank you for being the finishing in the time.
Thank you, Asim boss.
Thank you.
Thank you, boss. Please share the slides.
Swarangi, please, from your end, you please share the slide.
Today I am talking about response-driven management of HER2 positive in early breast cancer. Next. As we know, HER2 positive shows much shorter disease-free interval, and time to develop distant metastasis was worst for basal and HER2 type. And overall survival also very low before HER2 therapy came. Next slide. As we know, US FDA approved 8 HER2 targeted agents like trastuzumab, pertuzumab, TDM1, TDXD, and in oral lapatinib, neratinib, tucatinib. But in our majority of Indian patients, we have access to trastuzumab, lapatinib, and TDM1. Next. And to HER2 agent has did well as an adjuvant therapy. Next in. As we know, various trials, HERA trial, NSABP 31, PCI-RG trial, all have shown DFS and overall survival benefit in adjuvant setting. Next. What risk of recurrence should be minimized in HER2 early breast cancer? Next. There is chance of more than 10% of recurrence after HER2 neoadjuvant chemotherapy if pathological CR is not there, or tumor size is more than 5 centimeter, or skin involvement is there, or any nodal involvement is there. Next. How we can personalize our approach to reduce the recurrence rate? Next. By giving neoadjuvant therapy in tumor size more than 2 centimeter or any nodal positive, there is significant response in pathological CR. And if residual disease is there, chance of micrometastasis is there, and disease recurrence and metastatic chance are there. Next. Achievement of pathological CR matters so much in these HER2 patients in various trials. Next. Neoadjuvant therapy, which patient should be considered? Next. Mainly patient of inoperable breast cancer like inflammatory breast cancer, bulky fixed axillary limb node, and three nodal disease like supraclavicular skin involvement, T4 stage, and inoperable mainly T2 stage or nodal positive disease should be given HER2 therapy first as a neoadjuvant therapy. Next.
Dr. Sandeep sir, requesting you to please turn on your video.
Yes. Hello. Next.
Dr. Sandeep, can you please on your camera?
Camera.
Yeah.
Now I am visible.
Your fixed photograph is visible.
कुछ इशू है वो सब पता नहीं.
Okay, you continue, please.
Need of response adapted adjuvant therapy in HER2 positive. Next. In HER2 positive breast cancer, that patient having pathology, not having pathological CR, having low event-free survival and low overall survival, as graph are showing separation in between. Next. Building of trastuzumab, additional anti-HER2 therapy approved in adjuvant setting like TDM1, that biosimilar Uzvira is approved in HER2 breast cancer. After neoadjuvant, after surgery, if pathological CR is not there, so TDM1 is approved for 14 cycles, and pertuzumab, trastuzumab also approved. If pathological CR is there, we have to complete 1 year treatment. Newly, that niratinib also approved for extended adjuvant therapy on HER2 expressed for 1 year. Next. Access to this therapy in India, niratinib is not available in India, pertuzumab TDM1 biosimilar available in India. Next. That Catherine study is there. In that, minimum 6 cycle of chemotherapy with minimum 9 week of trastuzumab given. If residual invasive tumor is there, either in breast or axilla, then we have to randomize in 2 arms, TDM1 and trastuzumab. Out of that, TDM1 shown better IDFS. Next. That IDFS curve showing separation of that 11% difference is there. And in earlier study, that OS is not mature, but in current study, that 7-year OS is more than 4% in between. Next. That Catherine study final IDFS and updated OS in SAPS in recently that shown that the next. That shown that 7-year IDFS benefit of 13% at 7 year. Next, and overall survival difference of 4.7% at 7 years. Next. That has shown in all subgroups that TDM1 shown better response rate. Next. Next. So how these patients are classified? In pathological CR, we have to continue dual HER2 agents up to 18 cycle or 1 year. But if pathological CR is not there, we have to give TDM1 for 14 cycles. Next. That affinity trial, as discussed by Dr. Jitendra Bose, we have to skip. Next. Next. In affinity trial, mainly pertuzumab with trastuzumab shown benefit in node positive disease or T3, T4 disease. This is same slide I had shown. Pathological CR is there. Then trastuzumab we have to continue for 1 year. Otherwise, non-pathological CR, TDA1 we have to give for 14 cycles. Next. In summary, for patient with HER2 positive breast cancer, HER2 targeted agents shown rapidly improvement in overall survival. And for adjuvant therapy in Catherine study, TDM1 as adjuvant therapy in residual invasive disease showed IDFS benefit and overall survival benefit. And in affinity also dual HER2 agents shown IDFS benefit, especially in that node positive patients. Thank you.
Thank you, Dr. Sandeep Askar.
Thank you, boss. Actually, I am on the way to Bikaner. That's why.
No problem.
There, sir.
It was a good talk. And now I would like to request Dr. Charu Bahal. She is the consultant in molecular genetics, manager of the scientific affairs, MedGenome Lab, Bangalore, and she will be speaking on the biomarkers in lung cancer. And 10 minutes are given to this particular topic, a very important topic, but we need to concise in 10 minutes. So, Dr. Charu, over to you.
Thank you, Dr. Asim. I'll just share my screen now.
Yes, madam.
Organizer, can you all let me share my screen? Yeah.
Yes,
thank
ma'am,
you.
please.
Thank you so much. So I hope the screen is visible to everyone.
Yes, ma'am.
Yeah, so very good evening to everyone. So as Dr. Asim mentioned, I will be taking you through some interesting cases on lung cancer, just to illustrate the importance of genetic testing and biomarker testing in lung cancer cases, and some interesting, nuances which we come across these days because of the rapid uptake of genetic testing in the lung cancer patients. So, as we know, the common biomarkers which are identified in advanced non-small lung cancer are the ones which are already established include ALK, EGFR, RET, ROS1, ERBB2 mutations, NTRK, PDL1. And there are some emerging markers also, which are STK11, TP53, PIK3CA, NRG1, ERBB2 amplification, MAP2K1. All of these are upcoming ones. And the strategy right now is to go for a large panel so that we can include all the emerging and the current biomarkers in a single step study, and we can implement the large panel with the help of molecular tumor boards, which can essentially improve the therapy selection for non-small cell lung cancer patients. So as we know, the frequency of oncogenic drivers in non-small cell lung cancer patients, EGFR is one of the most commonest one, followed by HER2 mutations, ALK, and then in KRAS positive patients, we have KRAS G12C in almost 39% patients who are positive for KRAS. Then we have MET amplification, MET exon 14 skipping mutation. So all of these probably have a fair share of prevalence now because of the increased genetic testing uptake. So this is just a case scenario where I would like to explain how biomarker testing can illustrate the importance of intrinsic resistance. So mostly we see this was a 47-year-old male with advanced non-small cell lung cancer, and the patient was tested for SNVs, indels, and CNVs and fusions along with PDL1. So the treatment basically was started. If we look at the findings, the patient was found to have an exon 19 deletion, which is one of the commonest EGFR mutation along with TP53 and an FGFR fusion. So this is a newly diagnosed case which was not treated with any kind of EGFR TKI. So this FGFR3 fusion is one of the important resistance mechanism which can trigger in terms of presence of activation of the parallel bypass pathways. So as we can see here, EGFR itself has such complex mutation profile, like it can have various types of mutation. And if we look at the follow-up pathways like FGFR, so FGFR fusion can trigger a activation of bypass pathway. So in a newly diagnosed case when we find such types of mutation, it basically indicates that there is clonal heterogeneity, and clonal heterogeneity can be because of the pre-existing clones which are present before the treatment itself. So this resistance of the intrinsic resistance to TKI for this patient is not because of treatment of EGFR TKI. This is a pre-existing FGFR fusion which is found in this patient, and this basically decreases the efficiency of EGFR third generation TKI. And in terms of treatment, there are very few case reports where we can actually essentially decide what treatment should be given to this patient. As per the latest update, in this patient, the treatment selected was chemotherapy, which is pemetrexed and cisplatin plus osimertinib, and there was partial response after the 6 months. So I have the 6 months data for this patient. So the question arises is whether we can use a combination of EGFR and FGFR TKI, because if we look at the ESMO updates of 2024, it includes NRG1 fusions, and it also mentions the FGFR fusions as a pan pan tumor marker now, tumor agnostic, very well established. But since now it is included as a tumor agnostic, one of the tumor agnostic markers, it might be, a combination therapy might be tried. So this is where the molecular tumor board will be of help in such cases. Now, coming to the next part, which is liquid biopsy. As we all know, liquid biopsy has a major role to play in treatment monitoring in advanced non-small cell lung cancer, and also the selection of treatment in patients where we have limited tissue, or we want to capture the tumor heterogeneity and clonal evolution in newly diagnosed cases as well. So as we know, ctDNA testing not only helps in initiating the targeted therapy when it is done along with tissue biopsy profiling, but it can help us to monitor the response of the patient using serial plasma collections. So if we want to look at the acquired resistance, something like EGFR T790M, or we want to look at prognostic markers, or we want to understand what is the minimal residual disease that is left, whether the therapy is working or not, whether the disease is coming back or not. So in all those cases, the liquid biopsy is very primarily used in lung cancer nowadays. So obviously the efficiency of liquid biopsy and tissue biopsy is very well understood now, but just to give a fair idea, liquid biopsy can provide you both temporal and spatial heterogeneity. It can cover all the clones that are because we are not typing specific cells, we are taking like a part of quantitative sample from all the cells. So definitely it provides you better capture of all the cells in terms of spatial and temporal heterogeneity. But with tissue biopsy, the sensitivity of mutation detection is obviously going to be better than liquid biopsy.
Ma'am, sorry
So
to
in
interrupt
early stage,
you. Could you talk in next 2 minutes?
yeah. So if we look at this, I will just take you through an important case which can illustrate what I'm trying to say. So this is just a 58-year-old male where ALK-EML4 fusion was detected at the time of diagnosis using tissue biopsy. And in liquid biopsy, using liquid biopsy, it was monitored after each in 2023 and 2024. So 2023, we can see the the number of reads for ALKML4 became less, but in liquid, but again the next year it started coming back again. So we could see that coming up, and a MET mutation which is coming up as a secondary resistance pathway, which leads to basically the resistance towards the ALK inhibitor, and that is why these clones are coming up now, and ALK inhibitor is not able to work. So this is just how we can use liquid biopsy in order to establish the drug resistance mechanism. We should not only look at EGFR. If you're looking for EGFR drug resistance, just the EGFR gene, but we should look into the bypass signaling mechanism. That is very, very important these days. MET, HER2, FGFR, AL-cross, all of these are bypass signaling mechanism, including PIK3CA, MAPK pathway, and mTOR pathway. They could all be contributing to downstream pathway activation and leading to bypass signaling if EGFR TKI is not working properly. So definitely using liquid biopsy is becoming more and more important along with the tissue biopsy, and that's why at MedGenome we have launched a lung cancer duo test where we can do liquid and tumor biopsy together. A parallel testing will be done, and it covers 24 actionable genes both in liquid and tumor biopsy. And if tumor biopsy fails by any chance, you will definitely get the liquid biopsy result in 14 working days. So that is the approach we are going to have a comprehensive capture of all the mutations in a patient, and to provide a detailed and a better outcome to the patient. Definitely the lung cancer duo kind of a testing is what the future holds. So thank you so much for your patient listening. If there are any questions, I will be happy to answer.
Thank you, Dr. Charu Bahan, for your wonderful talk. And now it's good you have moved from 12 gene to 24 genes, and you are testing this liquid and tissue biopsy also. So this is cool, and obviously, if we have a more patients data, then we could say like which mutation and the rarest mutation we can find it out and we can target. Thank you very much for your insight. Thank you. Now we will move to our last speaker, and our star speaker, that is Dr. Rohit Ribello. He is from Udaipur. He is assistant professor medical oncology in Ananta Institute of Medical Sciences, Udaipur, and he will be speaking on 6-year survival in patient with extensive stage SCLC, small cell lung cancer treated with atezolizumab in IM Power 133. This is the umbrella extension study results. So over to you, Dr. Rohit.
Thank you, sir, for the kind words. I'll just share my screen. Please let me know if my slides are visible. Are my slides visible?
Yes, yes.
Yeah, okay. So let's just go through this. The 6-year survival in patients with extensive stage small cell cancer treated with atezolizumab and the IM umbrella extension study results. So what was IM Power 133? Basically, it was atezolizumab plus chemotherapy versus placebo plus chemotherapy in first-line extensive stage small cell lung cancer. So patients with measurable small cell lung cancer with a PS of 0 to 1, as in most clinical trials, and no prior systemic therapy were randomized to an induction phase of 4 cycles of chemo with atezolizumab, followed by maintenance atezolizumab until progressive disease or loss of clinical benefit, or the standard, etoposide carboplatin arm, followed by placebo till, there was no clinical benefit, with the primary endpoint being overall survival and the investigator assessed PFS. The key secondary endpoints were the objective response rate, duration of response, and safety. So this trial actually met its co-primary endpoint of improved OS, representing the first OS benefit in small cell lung cancer in 20 years. The curve started separating before the median, but diverged further afterwards. More than half of the patients in the atezo plus the carboplatin and etoposide arm were still alive at 1 year, which is something phenomenal, which we generally do not very commonly see. So the median OS was 12.3 versus 10.3, and the median follow-up was about 13.9 months, with a hazards ratio showing significance at 0.7, with the p-value being significant. When we looked at PFS, we also found that it met its co-primary endpoint of improved PFS. At 6 months, the PFS was 30.9% versus 22.4%, and at 12 months, the PFS was 12.6 versus 5.4, having a median of 5.2 versus 4.3. And here, even here, the PFS values were statistically significant. So this was basically in the IM Power 133, the primary PFS and OS analysis were completed in April 2018, and updated OS analysis was completed in Jan 2019. And some of these patients who were still living beyond that were then rolled over into the IM Umbrella A study, which had about 18 patients. They were eligible if they continued to receive atezolizumab at study closure, or were in survival at follow-up, were continued with atezolizumab or with survival follow-up. So it was a rollover from the previous IM 133 study. So if you look at the median age, there is a slight difference. These patients were a little younger, and age less than 65 had about 14% of the patients, whereas most about 77% of the patients. And if you look at the number of patients who had brain metastasis, about 11% had brain and 11% had liver mets. Although absolute numbers look very low, being only 2, because the total number of patients in the cohort was only 18. So when they covered the 5-year OS data, the median OS was actually 12.3 months in the atezolizumab plus in the IM Power 133 study. But if you look at the 1, 2, 3, 4, and 5-year survival of these patients, they were the 1-year survival, which is shown quite beautifully in the next slide, is the 1-year survival is about, the 1-year survival is 52%, as we saw there. The 2-year survival is 22%. But after that, we see some flattening of the curve, with the 3-year survival being 16%, and the 4-year being 13%, 5-year 12%, and 6-year 1. We tend to do, there is a small subset of patients that tends to do significantly better. So the 5-year OS is around 12% versus 2%, which is the actual 5-year OS with just chemotherapy. So there's a significant benefit, of overall survival. 12% of the patients with extensive stage small cells lung cancer are actually surviving up to 5 years. So the serious adverse events were seen in 27% of the patients, and this is a very beautiful overall survival rate across different small lung cancer studies that shows approximately the 1-year survival being 50 to 53%, the 2-year survival being 20 to 23%, the 3-year survival being 16 to 18%. So if you look at Caspian, which is Durva, as well as IM Power 133, there is definitely some benefit in a small subset of patients that is seen with adding immunotherapy to chemotherapy in a small subset. So there are patients that we can probably, very conservatively use the word cure or control at 5 years, which is something that we probably would not have thought of in significantly, in the significant past. So thank you. That is I wanted to convey by this talk. Open for questions.
Yeah, thank you, Dr. Rohit, for your nice talk. And I guess we will conclude this session today. This webinar was all about, you can say, the learning between the consultants and the audience. And we have presented like 4 abstracts initially about the breast cancer. And now later on, we had some discussion about the extensive stage small cell lung cancer also. So overall, I learned very new things today, and some of the trials were really changing, and some of them are confirming the long-term follow-up data, so that we can evolve with the new strategies in our clinics. And I wish to thank our speakers, Dr. You can say Dr. Rohit Ribello, Dr. Uttam Soni, Dr. B.S. Ankit Nehra, Dr. Manoj Mahajan, Dr. Preeti Agrawal, Dr. Sudhir, Dr. Divesh Goyal, and Dr. Bhavesh Palodia, Dr. Jitendra Pehlajani, Dr. Sandeep Bhaskar, Dr. Charu Bahal. So everyone were nice with their presentation. And I would like to thank our tech team also, Team Horizon, and our academic partners, pharma partners, and everyone who has supported us, and who has given the and the who joined this talk and webinar. So I wish to thank them, and we will be meeting tomorrow also with very interesting topic regarding hematology, and some of them are with the lung cancer. So for that, we will close for the day. And good evening, everyone. Good night, and thank you very much for joining us. Thank you.
Thank you, sir. Thank you so much. Thank you, everyone, for joining. Thanks to support team. Thanks to my colleague Dhruv, Sarangi, and Gitika. Thank you, everyone. Good night, everyone, till we meet again tomorrow.